Next, we're going to look at our alpha receptor antagonists. When you think about the alpha blockers, one of the side effects you should be able to predict for any drug that blocks alpha-1 is reflex tachycardia. Since these drugs are going to vasodilate, decreasing TPR and decreasing blood pressure, certainly you can get a reflex response at the heart. So let's draw a diagram. Let's look at this little cartoon and talk about that reflex tachycardia. So if I block alpha-1 receptors on blood vessels, the blood vessel is going to vasodilate. Pressure goes down, that leads to a reflex tachycardia activating beta-1s on the heart. But one of the things that limits that tachycardia is the alpha-2 receptor, which serves as our negative feedback receptor. So I get a reflex tachycardia, but it's somewhat controlled when norepinephrine feeds back to the alpha-2. So now you can explain why a non-selective alpha blocker, drugs that block both alpha-1 and alpha-2 receptors, can cause an even greater tachycardia compared to just an alpha-1 blocker alone. So a non-selective blocker, blocking both alpha-1 and alpha-2, would vasodilate, drop the blood pressure, cause a reflex tachycardia, but when the norepinephrine released from that nerve at the heart goes to feed back to the alpha-2s, those receptors are blocked. So I'm inhibiting my negative feedback. The nerve continues to release norepinephrine. So reflex tachy is even worse with a non-selective alpha blocker. There's a limited number of conditions where we can use alpha blockers. Hypertension is one, pheochromocytoma, and BPH, where in BPH we're trying to relax the smooth muscle to allow for easier urination. The first group of drugs that we're going to look at that are alpha blockers are those that are non-selective. The drugs phentolamine and phenoxybenzamine block both alpha-1 and alpha-2 receptors, and both drugs are used in pheochromocytoma. You remember that this is a condition where you've got a tumor of adrenal chromaffin cells releasing a lot of epi and norepi into the blood, causing hypertension, and so one of the ways to treat pheochromocytoma, especially prior to surgery, is to use a non-selective alpha blocker. We take advantage of their ability to vasodilate and lower the blood pressure in this condition. When I compare the two drugs, they have in common that they're both non-selective, but phentolamine is a competitive inhibitor while phenoxybenzamine is non-competitive. Perhaps an easy little trick for you is that when I compare these two drugs, the one with the shorter name has a shorter half-life, and it's also a competitive inhibitor because competitive is a shorter word than non-competitive. Phenoxybenzamine, the longer name, also has a longer half-life, and that's one of the reasons why we actually prefer this drug in the treatment of pheochromocytoma. I suppose if you get truly desperate and you're trying to remember what is that popular drug for pheochromocytoma, you simply count the letters in the name pheochromocytoma, and you realize the drug phenoxybenzamine has exactly the same number of letters. That's pretty cool. If you learned a rule of 10 for pheochromocytoma in pharmacology, let's call it the rule of 16, because there's 16 letters in the drug and the disease name. We have selective alpha-1 blockers. You would refer to these as the zosins: prazosin, doxazosin, and terazosin. These are all alpha-1 blockers that can be used for both hypertension and BPH, because alpha-1 receptors are found on blood vessels and they're found in the prostate. But we have one drug called tamsulosin that's spelled and acts a little bit different from the others. Tamsulosin is an osin, but not a zosin. What is special about this drug is that it blocks a subtype of the alpha-1 receptor known as alpha-1A. Alpha-1A receptors are found in high concentrations in the prostate, and therefore tamsulosin was designed to be more prostate selective and very good for BPH. But it's only used for BPH and not for hypertension. Make sure you read the question carefully. If you have a patient with both conditions, hypertension and BPH, the answer is a zosin. But if the question says you want to treat their BPH with minimal effects on their blood pressure, tamsulosin can be a better choice. We have one selective alpha-2 blocker to discuss, and it's the drug called mirtazapine. This drug is used as an antidepressant, and we will talk a little bit more about it in a later chapter. But let's say for now, can you rationalize the mechanism? I inhibit an alpha-2 receptor. That's like inhibiting an inhibitory receptor, causing the further release of norepinephrine. With more norepinephrine, that has benefits in treating depression. Depression, as you might recall, is a condition where you have low levels of two neurotransmitters, norepinephrine and serotonin, and all antidepressants are going to increase one or both of those neurotransmitters. Alpha-2 blockers can increase the levels of norepinephrine. Next, we will look at our beta blockers. When you think about blocking beta-1 receptors, we remember that beta-1s are found on the heart and the kidney. On the heart, you're going to see a decrease in the heart rate, stroke volume, and cardiac output. But on the JGA cells of the kidney, you see a decrease in renin release when you block beta-1 receptors. If you block beta-2 receptors, in many cases, you can get some side effects that are unwanted. Bronchospasm can happen in asthmatics. Vasospasm can happen in patients with vasospastic disorders. Many times blocking the beta-2 leads to unwanted effects, as we see here. But there are times when blocking beta-2 can be beneficial. For example, non-selective beta blockers are used in glaucoma because it's the beta-2 receptor that, when it's stimulated, increases aqueous humor production. So a non-selective beta blocker decreases the production of aqueous humor, thereby lowering intraocular pressure. We've previously discussed the metabolic effects of beta-2 stimulation. If I block beta-2, I'm blocking glycogenolysis and gluconeogenesis, so I lower blood glucose. Beta blockers can also increase LDLs and triglycerides by preventing the breakdown of triglycerides, and this is an action perhaps it's happening on adipocytes. It also may involve an additional beta receptor known as beta-3, but that's unclear at this time. This table shows us the different beta blockers. It's very easy to recognize what I would call a true beta blocker. The way you can recognize a true beta blocker, it ends in the letters OL, OL, as we see all of the drugs in this table do. The next task for us is to decide, is it beta-1 selective or is it beta-1, beta-2, meaning non-selective? The easiest way to remember is to remember that if I look at the beta blockers that start with the letters A through M OLols are beta-1 blockers only. But beta blockers that start with the letter N through Z, in fact, remember the letter N for non-selective, those are all of my non-selective beta blockers. So acebutolol, atenolol, metoprolol, all beta-1 selective, whereas pendolol, propranolol, timolol, and maybe perhaps other drugs that you can think of, like a drug called nadolol, starts with the letter N. N is in the second half of the alphabet, N for non-selective. Nadolol is a beta-1 and beta-2 blocker. The second column here talks about the property of beta blockers known as ISA, which stands for intrinsic sympathomimetic activity. Now, intrinsic sympathomimetic activity is kind of a fancy way of saying partial agonist. Two beta blockers have partial agonist effects. That would be acebutolol, a beta-1 selective drug, and pendolol, a non-selective beta blocker. Those are two drugs that can actually stimulate beta receptors, but of course in the body they're going to compete with epinephrine and norepinephrine, and their net effect is to antagonize those full agonists. So they actually function as beta blockers, but they have the special property of being partial agonists. The third column looks at the sedative effects of beta blockers. Propranolol in particular is a sedating drug. In fact, of all of the beta blockers listed, only atenolol lacks that sedative effect because it does not effectively penetrate the CNS. And finally, in the last column, if I look at the effects of beta blockers on blood lipids, the rule is most beta blockers will raise triglycerides and LDLs. But notice, 2 of them do not, and they correspond to the 2 drugs that are partial agonists, acebutolol and pindolol. And perhaps you can think about this, since they are partial agonists, they function kind of as weaker antagonists compared to the other drugs which are true antagonists, and their side effects profile is not as bad compared to the others. So they have less of an effect on your blood lipids because of being partial agonists. You should be able to determine the advantages of being beta-1 selective. Sometimes that's referred to as cardio-selective. Those types of drugs are going to have less effect on the vasculature, on the lungs, on the uterus, and on metabolism. So beta-1 blockers are preferred, especially in patients who have asthma or diabetes or peripheral vascular disease. In the table, we discussed the 2 drugs, the 2 beta blockers that have intrinsic sympathomimetic activity. And again, to summarize the advantage perhaps of those drugs, minimal changes in plasma lipids. We also saw in the table the pharmacokinetic property of atenolol. The fact that it does not penetrate the CNS means that it's not going to cause sedation, which seems to be a common property for other beta blockers. In the margin, there's a clinical correlate discussing the chronic use of beta blockers leading to receptor upregulation. It's for this reason that you never want to immediately discontinue a beta blocker. Always taper the patient off to avoid excessive cardiovascular effects. That rebound tachycardia can be quite significant. In fact, you have patients that are taking beta blockers post-MI to prevent a second MI. If that patient abruptly discontinues their beta blocker, the risk of a second MI definitely increases. Always taper them off. There's another clinical correlate in the margin that discusses the use of glucagon in beta blocker overdose. You see, glucagon can actually be an antidote to beta blocker overdose, and this is all about how your G proteins work. Remember, if I block beta 1s, since all betas are GS, I'm blocking the increase in cyclic AMP. The net effect of a beta blocker decreasing the cyclic AMP levels in the heart. When I give glucagon, glucagon works through its own receptor, which is actually GS coupled to adenylyl cyclase. Glucagon will increase cyclic AMP levels in the heart, and that's how you can overcome the actions of the beta blocker. In fact, it's a way to physiologically oppose those beta blockers. There are lots of uses for beta blockers. Many of these are cardiovascular benefits in angina, hypertension, post-MI, and as antiarrhythmics. Follow this basic rule. If I'm going to use a beta blocker for a cardiac condition, our favorite drugs are those beta-1 selective blockers. But we have other conditions. In fact, these conditions are where non-selective beta blockers are most likely to be used. Glaucoma, where the drug timolol is useful because of its ability to block the beta-2 receptor and decrease aqueous humor production. Migraine prevention, that's another popular use. Beta blockers are the most commonly used drugs for migraine prevention, and non-selective beta blockers are the most popular there. Thyrotoxicosis is something we will discuss later on. Performance anxiety we'll also mention, but in both of those situations, non-selective beta blockers are commonly used. And also in essential tremor, where the drug propranolol is used. Notice again, non-selective beta blocker. Watch out for essential tremor. It's actually more common than a lot of people think, and this condition can be treated by beta blockers. We have a couple of drugs here that have additional properties besides just being beta blockers. The rule that I give you on this is if the drug name ends in the letters OLOL, that is a pure beta blocker. It's a beta blocker only, and you've already figured out how to decide, is it beta-1 selective or is it non-selective? Now, notice if the spelling is modified. If the letter OLOL is changed to I, LOL or ALOL, that means it's a beta blocker plus something else. So the LOL perhaps can still remind you of beta blockers, but the fourth letter from the end being an I or an A says that drug has an additional property. Take, for example, the drug labetalol. It's probably my favorite out of the three for whoever named and spelled this drug the way they did. Labetalol, A-L-O-L. LOL can remind me of beta blockers, and A because it also blocks alpha-1 receptors. It's an ALOL, it's an alpha and beta blocker. We have a drug called carvedilol, spelled I-L-O-L. It's not as useful of a spelling for us, but it does tell us this is a beta blocker that has additional activity, and carvedilol also blocks alpha-1 receptors. Both of these drugs will show up in our later lectures for heart failure or for hypertensive emergencies. Our third drug here is called sotalol. A drug that ends in the letters ALOL reminds us that it's a beta blocker plus something else, and this time that other thing is sotalol is a potassium channel blocker. Because there is no quick and easy way to remember these three, here's what I'm going to suggest. You recognize the change in their spelling, either ALOL or ILOL. I would learn the drug sotalol first. If I learned that sotalol is a beta blocker and a potassium channel blocker, the other two drugs with alternate spellings are the ones that block alpha-1 receptors. Now that we've finished Chapter 3, let's do some practice questions. Stop the video, review the question, and then I will come back and discuss the answer. We have a 76-year-old man with a history of prostatic hypertrophy. He has a recent onset of increased difficulty urinating. You'll notice that his symptoms began shortly after he started taking a nasal decongestant for cold symptoms. We want to know what receptor is likely involved in these adverse effects. Well, you have two very important clues in this question. First, BPH, and second, he's taking a nasal decongestant, probably the drug phenylephrine. Both of those make you think of alpha-1 receptors. Choice A is the correct answer. Here's question number 2. Stop the video and review the question, and then we will discuss. A man suffers internal bleeding that causes his blood pressure to decrease. This causes a sympathetic response in his arterial or smooth muscle. We want to know what intracellular second messenger will be activated in these cells. In order to solve this problem, you have to work your way through the receptors. The pressure goes down. We're going to fire the sympathetic nervous system, and we're firing the sympathetics in this case to the blood vessels. What is the receptor on blood vessels that's innervated by the sympathetic nervous system? You remember the cartoon that we drew earlier when we were discussing muscarinic receptors? The only one of those receptors that's innervated on the blood vessel is alpha-1. And alpha-1 vasoconstriction is going to increase TPR, and that would be the appropriate response to a patient who has internal bleeding and a drop in pressure. The question then says, how do alpha-1s work? Alpha-1s are coupled to GQ, which is the phospholipase C, IP3 and DAG pathway. Correct answer here is C, an increase in IP3. Now, many of you may in fact have chosen choice A, an increase in cyclic AMP, and there's probably a couple of reasons for that. Probably the main reason you chose it is because you're thinking it's always cyclic AMP. That's the most important of all those second messengers, so it's got to be cyclic AMP. But think about that effect. If I increase cyclic AMP in smooth muscle, what happens to the smooth muscle? It vasodilates. It's going to relax, and that's going to drop the blood pressure even further. So that response would not be consistent with the benefit that we're looking for in this case. Here's question number 3. Pause the video, and then we will discuss. Cells of the adrenal medulla secrete catecholamines when the sympathetic nervous system is powerfully stimulated. Which of the following neurotransmitters is used to activate the chromaffin cells? When you read this question, make sure that you carefully think about what's going on, because sometimes you can answer questions a little too quickly. Is this question asking you what is released from the adrenal medulla or what is activating the adrenal medulla? This question wants to know what transmitter activates the adrenal medulla. It's another way of saying who's the first neurotransmitter, and we know it's choice A, acetylcholine. If you chose epinephrine or norepinephrine, you are actually answering the question of what is released from the adrenal medulla, and that's not what's being asked here. Here's our fourth question. Pause the video and then we will discuss. A 25-year-old woman at 32 weeks gestation begins taking a drug to delay the onset of preterm labor. What side effect might be expected from this drug? It's a question where you have to determine the type of drug that she's going to use. Since she's got preterm labor, you want to relax the uterus, and the type of drug that would do that would be a beta-2 agonist. A drug like terbutaline would be useful. Now, match up the side effect of beta-2 agonists with what you're given. In fact, let's go through each of the answer choices. Is terbutaline as a beta-2 agonist going to cause bradycardia? No, in fact, these drugs are vasodilators. Beta-2 activation on blood vessels vasodilates, drops the blood pressure, causes reflex tachycardia. Because you're going to vasodilate, you don't get hypertension, you get hypotension. Because you're vasodilating, you can actually dissipate heat more effectively, so you don't get hyperthermia. You get hypothermia, if anything. Hand tremor. Remember that skeletal muscle contains beta-2 receptors. Systemic beta-2 agonist administration can result in skeletal muscle contraction and possible hand tremor. Choice D is the correct answer here. You also don't get urine retention with beta-2 agonists. Urination is really more of a function of muscarinic receptors and alpha-1 receptors, with really no effect of a beta-2 agonist on that situation.